My name is Chris Childers. I'm a surgical oncologist at the University of Washington, and I'm delighted to be able to spend a couple of minutes talking about our latest paper out in the journal. Everybody is familiar with the idea that surgeons are paid a fixed amount for a given operation, regardless of that operation's complexity, whether it's a little bit easier or a whole lot harder. We published a paper last year that was looking at Modifier 22. Modifier 22 allows surgeons to identify cases that have exceptional complexity and are supposed to be reimbursed more, but that paper found that that doesn't actually work. And so our group, in collaboration with the American College of Surgeons General Surgery Coding and Reimbursement Committee, we're interested in seeing if there are patient factors that are consistently associated with increased work that could be potentially used in advocacy efforts moving forward. Obesity was the concept that came up with our group over and over and over again. We know that obesity rates have been increasing around the country. We are all very familiar with the challenges of operating on these patients, from getting them to the operating room, positioning, draping, everything associated with taking care of them in the operating room and their post-operative management. And so the question which we wanted to answer was, how does obesity impact surgeon work in common abdominopelvic operations? We used 2022 ACS NSQIP data. We looked at 10 common operations, some of them MIS, some of them open. And the main measures of work that we used were operative time, skin-to-skin time, as well as composite measures of complications. And we defined different overweight and obesity categories using standard criteria. And what we found, perhaps not surprisingly, was that, sure enough, with increasing obesity category, there was an increase in operative time. But that effect was incredibly consistent across all of the operations, and it was very stepwise, going from 5% in the overweight category to a 25% average increase for patients with extreme obesity. And so in summary, obesity class is consistently associated with increased surgeon work across a broad spectrum of abdominopelvic operations. And we think that this has significant advocacy implications for surgeons. Obesity would be an ideal target for something like a CPT modifier or an add-on code, and our group intends to advocate for that for surgeons moving forward. Thank you for taking the time, and I look forward to answering any questions that people might have as they read through the paper.